All right, let's get started.
All right, everybody, please find your seats. We're about to get started. Thank you for coming, and thank you everyone online as well. Welcome, my name is Zachary. I'm a librarian here at Northeast Harbor. Thanks to the generosity of our donors and the collaboration with presenters like Northern Light Health, we're able to offer free programs like this year-round. Coming up this Friday, September 27th, we're presenting local playwright and actor Andrea Lepsio in her one-woman show, Human. If you'd like to see more about the library's upcoming events, please subscribe to our email newsletter. There's a sign-up sheet by the door as well, and please indicate if you'd also like to hear from Northern Light Health. Tonight's presentation, arranged by Northern Light Health, will cover hospice and palliative care services available in our region. Please welcome our moderator for the evening, Jennifer Lloyd.
Good evening, everyone. Thank you so very much for taking the time to join us tonight. I am your moderator. As I was introduced, I'm Jennifer Lloyd. I'm a philanthropy officer for Northern Light Health Foundation, serving the needs of oncology throughout our region. It's my very great pleasure to be with a very esteemed panel that is going to address the questions that we all have, I think, when it comes to this subject. We're going to start with self-introductions. I'll start with the first person on my right. Please introduce yourself and we'll move along, and when we conclude with introductions, we'll get into the questions for the evening.
Hi, I'm Cosmina Fasciol. I'm a palliative care physician at Eastern Maine Medical Center. I've been in this position, it's going to be 14 years next month. So.
Hi, I'm Donna Curley. I'm a physical therapist. I'm the Associate Vice President of Home Health for Northern Light Home Care and Hospice. I've been with our agency for 7 years now.
I'm Erin Kearns, a licensed clinical social worker. I'm manager of clinical services for our Hancock County service area for both our home care and our hospice programs. And I have been with the organization for 18 years.
I'm Vanessa Little. I'm a palliative care doctor. I live right down the road, and my kids go to school right here. And I have been working with Northern Light for the last 3 or 4 years. I worked with them even before that in the hospice team with Aaron, and I worked at MDI Palliative Care as well.
Excellent. Thank you all for joining us tonight. Our first question is for all of you. Please help us understand the difference between palliative care and hospice care, as there seems to be some confusion. Who would like to take the question first?
I can take it. So palliative care takes care of patients at any stages of a life-limiting, life-threatening, or serious chronic condition. There's no restriction as to what their life expectancy is. So we oftentimes see patients from the beginning of their problems, from the diagnosis of a serious illness, for example, cancer, and we follow them throughout their illness. And we follow them in various settings. We sometimes see them in the hospital first, and then we follow them in our clinic. We used to follow them in nursing homes before, and we're trying to get back to that. We sometimes see patients for many years. I just recently lost a very dear patient of mine at the age of 96, and I didn't even realize until her son pointed out that I had seen her for 7 years prior to that. So we see patients, especially now with newer therapies, even for cancer patients, we sometimes follow even cancer patients for many years. Palliative care is, like I said, not restricted by any life expectancy issues. Hospice patients, on the other hand, in order to qualify for hospice services, a patient, in the opinion of 2 physicians, should have a life expectancy of 6 months or less if the disease follows its usual course. Of course, some patients outlive that, and sometimes they do because they get better care with hospice. And if they continue to have a serious illness that's expected to decline, they can be recertified for hospice, but they still have to have that stipulation that they have to have a life expectancy of 6 months or less in order to qualify for hospice.
Excellent, thank you. Anything that either of you would like to add to that?
I'd say both services are usually provided by a team, and hospice is also a Medicare benefit, so it also changes how the care is reimbursed. Like palliative care gets billed to insurance, and usually hospice is a whole comprehensive benefit, so medications and all the visits from the staff and any DME, those are all included and free for the patient. And both also, it's not just the patient, we call it the unit of care as the patient and family. And so both in palliative care and hospice, we're attending to, we recognize that the person living with serious illness, that impacts the whole family, caregivers, friends, and such.
I'm just curious in regards to the difference between palliative care and hospice and the treatment that they might get, such as going to the hospital or doctor's appointments, and how that is the same or different.
Yeah. So under when people are having palliative care, it's billed, so they're utilizing their, think of it as a specialty. So like people go to cardiology still, right? So this is a specialty, like cardiology, it's palliative care. And so they still are accessing their full insurance benefit and having that specialty. Under hospice, people are coming in, and then hospice is overseeing that entire plan of care. So hospice is covering and taking care of that patient or that unit in the entirety. And so if somebody's then accessing their insurance benefit outside of what that hospice is providing, it may not be covered if it's related, unless the hospice is the one to coordinate that with the, whether it be oncology or cardiology or a hospital. So hospice has to be involved and has to be a part of that hospice plan of care.
So if they're on hospice and they're at home and they decide to go to the hospital, how does that all work?
If a patient is at home and they have hospice and they decide to go to the hospital, it happens two ways. The preferred way, which we don't always think about, because when we're wanting to go to the hospital, we tend to feel like it's an emergency and would want to call 911 and go, and that's certainly going to happen. And so that's one way that happens. So there's a couple of things that we would like to do or to try to avoid when that happens. But if a patient is at home and they have hospice and they feel they need to go to the hospital, the first call really should be the hospice. And then the hospice works with the patient and family. Can we manage whatever the symptom is, whatever that need for feeling of hospitalization is? Can we manage that in the home? If we cannot, then we're calling and coordinating with the hospital. We have a patient, we need to have come inpatient, do general inpatient level of care, and that's one of the levels of hospice care that we can provide. And we do have agreements with our local hospitals to be able to provide that level of care. So if a patient, because this is what happens, I mean, this is what you're getting at. If a patient ends up at the hospital and the hospital doesn't know their hospice and we don't know they're there, then it can be a little bit messy, right? Because their insurance is tied to hospice and is not covering the hospitalization because it's not been authorized, we're not involved. So it is really important if our patients do that. And when I would do an informing, I would always say, if you happen to end up at the hospital without notifying us first, please let them know that you're a hospice patient. And if we're not your first call, if we want to be your first call, if we're not your first call, if you call 911 first, make sure somebody's telling us that you're going there, so then we can coordinate with the hospital and make that work. I mean, the ultimate goal is to take care of the patient and make sure that they're comfortable, right? So we need them to be in the right environment to do that. And if we can prevent them from having a hospitalization, that's great, right? We want to be able to keep people at home if at all possible, or whatever their home is.
So to kind of jump on what you just said in regards to letting them know that they are a hospice patient when they get to the hospital, how does that change what a hospital will do for their care, if at all?
So if they let the hospital know they're hospice, we need to be notified, right? So then we get involved, and then we're gonna collaborate with the hospital and the patient and the POA on what that plan of care is gonna look like. Because the patient has a choice, obviously has a choice. If they decide that they no longer want hospice and they wanna sign off of hospice to pursue some aggressive medical attention, which is not included in their hospice plan of care or the hospice philosophy, they have a right. And so we as the hospice we don't tell them what they do, but we have to make sure that they know what their rights are. And so sometimes it takes the coordination of the hospital, the patient, the family to determine what it is, what's the patient's goal, right? Like that's the ultimate, what is the patient's goal? And then going from there, letting them know their options and then letting them go there. And oftentimes it's, you know what, I fell, I, needed some stitches and I want to go back home on hospice, great, like let's help you do that. And then it's just, a quick visit to the ED, back to home.
So if somebody breaks their femur, they can get the surgery, come off hospice, get whatever.
If somebody breaks their femur and they go to the hospital and we're involved, like we know, like somebody's been called, because this happens, right?
Yes, it does.
So if we're called in that time frame and we work with it, we would be going to the hospital, okay? Generally, the patient would have an x-ray to confirm the fracture. And then we also have to take into account, is the patient rehabable? Is the surgery, can the patient have surgery, right? So worst thing that a patient could do is fall, break their hip, sign off, or break their femur, sign off their hospice benefit, and then not even be able to get treatment, right? Or they go to the hospital, we confirm it's fractured, we consult with ortho, know that they're not able to have surgery, they're not a surgical candidate, and then we have them transferred back to home, still under hospice, continuing to provide hospice care. And it's an increased level of hospice need, support, and pain management at that point.
Can I just add something to that, which I missed saying before? When somebody gets admitted to hospice, they have to have a hospice qualifying diagnosis. And they shouldn't be returning to the hospital if their symptoms are related to that hospice qualifying diagnosis. For example, if somebody has cancer and they have symptoms related to their cancer and the symptoms are difficult to control at home, they should call hospice. Hospice will work with them, getting them controlled at home. If that's not possible, admit them to the hospital still under that benefit. However, if somebody has other diseases that they want to continue to manage, they can continue on those medications. They're just not going to be covered under hospice. And the same thing is if somebody breaks a bone, like Erin was saying, if it's completely unrelated to their hospice diagnosis, sometimes they can continue under their hospice care while they're getting the care that they're needing. I think patients are often frightened by the idea of not being able to return to the hospital. So when you talk to them about this is their major thing, so I'm never going to be able to come back to the hospital. And we need to be very clear that yes, they can. Whether they can stay under hospice or they have to revoke that benefit and be readmitted later, but they definitely can come back to the hospital, and they can come back to the hospital if their symptoms are not controlled at home.
I think
I do want to say that I used to work for a parent, so. But I know a lot, so.
I think one thing to add, it's great, is home health and hospice. We're really a partnership. So home health, we typically see patients when they're discharged from the hospital and they have that acute need. But along with that, we're really treating the whole patient, right? That whole body approach. We have a lot of patients that have a chronic illness. So we really work with that patient on what are your goals? Where do you see your care going? At that point, as they start to progress, we pull in our hospice team and we really partner together to meet with them, to get them what they need to understand with what hospice can provide as early as possible to help with that transition for them and also their family, to get them the support that they need. So it's really great that we're able to have that partnership.
Can you help us understand, under the umbrella of palliative care or the umbrella of hospice care or home care, what other specialties would fall under those that are different from one another? Or maybe they're not, maybe they're all the same. For example, are all availed to clinical social workers? Or would you only find that if you were availing to receive hospice care? Could you expand on that for us?
I can talk about what it is like in home care and hospice, and maybe Vanessa or Cosmina can talk about it in palliative care, but under home care and hospice, much of our team with our Northern Light team in Hancock County is the same. The clinicians were on the same team, the home care and the hospice team. So I'm managing the home care and I'm managing the hospice. And so the social workers, the home health aides, they're also both. So if we have a patient that has home care services, and then we transfer them to, they transfer to hospice services, they're gonna have some of their continued care team. The nurse that may have been their home health nurse, there's the potential that that nurse could still see them, that those nurses rotate through call rotation, so it's part of the same, really the same team. Some other organizations have it more split out, but we're the same.
Isn't that great?
Yeah.
That's wonderful news for a patient, because as having been one, I think probably many of our viewers have been one or cared for one. That's one of the most disconcerting feelings for a patient, is the change and meeting someone new when you've been just developed a relationship with someone who you've had intimacy with, because they're meeting you in your most vulnerable state. So I love that with Northern Light Health that we have that opportunity to provide real holistic and continued care.
We also, on the, there's a few additional team members, right? So on our, once we merge over into the hospice, we have bereavement services, and so that would be, we have a bereavement coordinator, we also have a spiritual counselor who also sometimes assists with some home care patients or palliative care patients if they have a spiritual need. And then on our home care team, we have therapies, so speech therapy, occupational, physical therapy, and those therapists are also coming over onto the hospice side if we have a hospice patient who's in need of some of those services. So maybe not for like the rehab services, but if we had somebody who needed speech for a swallowing eval, or to be able to communicate to their loved one, to put some mechanisms into place for that. So we would have our therapists come on board for that as well.
Excellent. Anything else to add to that question? All righty.
Do you want me to speak about it for palliative care?
Sure.
I think one of the challenges with palliative care right now is that different programs can look different, so you don't really know exactly what all the members of a team are going to be until you know a particular program. But I know that for Northern Light Palliative Care across the system, we're trying to make it so that it's more similar, so that patients will know what they can expect no matter what their area code. But also that your palliative care team might not all just be who specifically has a palliative care name tag. Like, it's all the rest of your medical team that is part of your care team.
Excellent, excellent, thank you. And while we're with you, Dr. Little, you've worked at both MDI Hospital and Northern Light. Please help us understand the services available to the island residents.
So I had the honor of helping MDI Hospital develop their palliative care program through some very generous local donor funding. And so we got to try something new and develop a program that would have been difficult to do otherwise. That program still exists with a nurse and a social worker who see patients in the hospital and also at home and do telephone support. And that they'll serve patients that have an MDI hospital provider. And then we, and also in this area, we have palliative care provided by Northern Light. Many patients find it convenient to go to Eastern Maine Medical Center or the Lafayette Family Cancer Center, where they might be receiving treatment, where they can see Dr. Fasciol and her colleagues there. There's palliative care now at Maine Coast and Blue Hill, where they have clinics, and also to home visits and telehealth visits. We have inpatient palliative care now within Northern Light for hospitals that don't have their own in-person team, like EMMC has Dr. Fasciol's team, but the more rural hospitals don't have a team, so we provide palliative care via telehealth in those settings. And I will say, I'm surprised at how much people have welcomed the robot machine into their room to talk about really intimate conversations. And I think that they're just grateful for the conversation, and I think people are getting used to the technology.
Wow. So at Northern Light Health, we hear a lot of making care work for you. It sounds like in this regard, you really have. So that's wonderful. Thank you for sharing that. Now, Erin, as the manager of clinical services for Northern Light Home Care and Hospice serving this region, please describe how the island residents can specifically utilize hospice services.
For our hospice program, we're open, we serve all of Hancock County, slightly into Washington County as well. and fully open. And so it's a referral from a provider, or sometimes patients will call themselves and ask to start having the conversation about hospice, which then we would do, and we would need to then work with their provider. So we have been fully open to, we're fully staffed hospice team providing support to the island, no gaps in that. We also go to the outer islands, so we've had patients on Swans or Cranberry Islands, which takes some advocacy, coordination, but people who live on the island generally are used to having to kind of figure that out and be creative and innovative and what that looks like. And so we work with them to figure out how can we do this, because can only get there when there's a ferry going over. We're not going to be able to get there in the middle of the night. And so what would that look like? And so one of the things that we've done for our island patients, and we actually started this a long time ago when we served somebody on Isla Ho, we started putting a tablet in the home, so much like our telehealth equipment that we would use for some of our home care patients to monitor vitals, but this allows us to do a video visit with the patient so that our on-call nurses could have a video visit with the patient to be able to see and be able to instruct the caregiver. So a lot of, hospice is a lot of teaching anyway, but it's a lot more teaching and planning ahead when we have an island patient, because we really have to think about everything that could happen and making sure that the tools and the resources are there for everything that could potentially happen.
Wow, sounds like a lot, but sounds like you've got that locked down.
It is rewarding. I'll say, to be able to know that we're able to provide something that maybe someone else can't provide, it's a challenge, right? And it's knowing and hearing the feedback from the patients on the islands that we serve is huge. Just, it's touching, and the team just kind of rallies around that, and we're going to make this happen, and very, very positive to be able to provide that work, that level of care.
Yeah, it's very impressive. Getting care close to home is something else that's one of our core values, which is why this conversation is so important to us. And I can imagine, when I think of being a distance from home, I'm just getting in the car to bridge that distance. But the hurdle of having to cross a waterway would certainly make not being home feel much further. So I think that must be a much gratifying thing to meet those families and those patients and get their feedback as to how much this is really helping them. So thank you for all you do. So Donna, your turn. Please share with the group how you have collaborated with the Mount Desert Nursing Association to better serve island residents.
Absolutely. So over this winter, we reached out to Mountain Desert Nursing Association to start a conversation and to discuss how can we better support each other to help to support all the patients throughout Mount Desert Island. Through that, we did work with them and to provide them with some skill set training, and that allowed that agency to help to expand the patients that they're able to serve. We, of course, still continue to see patients throughout all of MDI, and as Erin already referenced, we continue to provide hospice services everywhere.
Wow, that's wonderful. That's the conclusion of my formalized questions, and now I'd like to open it to the audience. What types of questions might any of you have for our panel?
You're all looking at me.
Bring it on.
Well, just some of the things that I was, what you were kind of bringing up, and as I said, I worked 3 years with Northern Light Hospice, and we talked about the islands and everything. One of the things, and I really didn't think about that, is even the very end of life. How does that happen, and how does that person get off the island? And that's all kind of stuff that hospice does work with to plan. Yeah, you're planning the whole way through, but even planning that end and how that person comes off the island and everything. So
A lot of logistics, like how do you get durable medical equipment out to an island, and how do you make sure that you have the right medications? And very fortunate in this community that we've had some local providers willing to be flexible and work with us in making these things happen for the patients. So.
Yeah, I want to add to that, because I think an easy thing for a business to do is to say no. And then the patient is going to be out on the island with nothing, with no hospice support. And the harder thing to do is to say, yes, we're going to figure it out. It might not look exactly how we're used to, but we will collaborate with the patient, like Erin said, that has chosen to live a life on an outer island. They are used to relying on their neighbors and having limited bed of ferry, etc.
I think for under hospice care and home care and palliative care program, it's individualized to the patient, right? And so there are some patients who, we may need to see daily when they're at the end of life. We're not going to be able to get to the islands daily, the outer islands daily, so how do you plan for that and what does that look like? And so it's that constant planning, it's building that plan of care around the patient and their family and what they're needing, just as if they were living here. It's just, it looks different, looks different. And there's requirements, we have certain requirements for how frequently we have to see patients or have a nurse see a patient. And so, that requirement for Medicare is, once every 2 weeks or once every 15 days for the RN assessment. And when we have someone on an island, that might be okay for the first couple of months they're on care to go out every couple of weeks on the ferry. But then there are times when it's 2 times a week and maybe some video visits. And so it increases and we have to increase that.
Excellent. Do you have a question?
I do, actually.
Okay.
Having professionally worked with several of you, personally have used Northern Hospice Services, thank you. So I think the care you provide is extremely comprehensive and patient and kind, so thank you for that. What are the common misconceptions that you feel exist with your service, or people in our community not understanding or having yet thoughts that maybe not are?
I'm gonna die. If I go on hospice, I'm gonna die, and it's gonna be quick, right? Like that, or they're gonna push morphine and it's gonna kill me, right? So it's misconceptions about medication, it's misconceptions about, speaking for hospice, it's misconceptions about the program itself. I mean, there is no greater joy than having a patient who is able to fully live and do the things that they wanna do. They wanna go to a concert at the waterfront, how do we make that happen for them, right? Like, we want these patients to live and live their fullest, and so those are the things that we're making happen. We're not pushing the medication and encouraging people to die. We want them to live. We want to be with them. We want to support them through this. So it's really about the living. And if there was one thing I could change, it would be hospice is really about the living, not the dying.
That's excellently said, thank you.
I think another misconception is that palliative care is hospice. So we have to educate people all the time. I think there's more and more awareness of what palliative care is, but I don't think there's a day in clinic or in the hospital when we don't have to explain this 2 or 3 times to families. They get referred to palliative care, they can come to our clinic, they have no idea what palliative care is. Even though we send them a flyer with some information in the mail, nobody reads that. So a lot of times that's what they're saying. So you're the same as hospice. I don't want hospice. I'm not ready to die. So that's one of the first things that we need to clarify with them. And when I talk about palliative care, I say palliative care does 3 main things. It is taking care of patients who have some sort of life-limiting, life-threatening chronic illness, taking care of their symptoms, because that's a major thing that families and patients are concerned. So if they hear that we're here to help with your pain, with your nausea, with your depression, you kind of put them at ease from the beginning. The second thing that I say we do is we help a lot coordinate with your other care teams, because a lot of these patients see many specialty physicians or providers, and they don't get the big picture. So we kind of try to put it all together, whether it's in clinic or in the hospital, by having meetings with other providers or just sitting down with them and explaining the whole picture. Sometimes we see patients with dementia who have seen neurology and geriatric psychiatry, and nobody has told them that this is a terminal illness and this is what to expect, and you have to plan your finances and you have to plan for your care in the home moving forward. So that's the second thing. And then the third thing that we do a lot of is advanced care documentation and planning, making sure that, like everybody here said, there is a discussion about goals of care that is then documented, whether it's in the advanced care directive or just in the chart. So other people who look through the chart then can see what has been discussed and take it from there. So.
Erin, I really think you did a nice job just expressing how hospice is all about living. That was beautiful. I was actually wondering if you could provide some more information on the extra support that gets wrapped around the family after their loved one passes.
Sure.
Thank you.
Thanks, Donna. So bereavement services, which I briefly mentioned before, but one of the Medicare requirements for medical hospice is that we provide bereavement support to families after their loved one has died. And so we do that in different ways, but it's a 13-month period of time. And it's not billable, it's just part of what we do, it's encompassing. And so we try and build that relationship. We love it when we can have our patients for longer than a few days or a few weeks, right? Because we want to help them live. We want to help them have successes and have good days, within their last 6 months to a year of life. And so we get to know them, right? And so we may know when we do bereavement, like risk assessments and some of the things that would trigger, maybe somebody needing more support after death. And then we have bereavement coordinators, and the one that serves here in Hancock County is also our spiritual counselor. And so he's already met a lot of our patients and families before the patients die. And then he's following them. So we're reaching out as a team. Generally the clinicians are reaching out shortly after the death. I mean, we're providing death visits, we're helping in that moment, but also in those days following, reaching out, and then providing in that 13 months. And for some people, it's, they don't want a lot of support, right? For some people, they just want to hear from us by mail and know that we're there. I find in the 18 years that I've been doing this, the common timeline is people may decline bereavement support for like 6 months, and then at the 6-month mark, that's like when, oh, wait a second, we need something. And so we don't close that, right? We want to leave the door open. We want people to know we're still there, even if they don't want visits or calls right after the death. But we want them to know they're there so that that support is available to them in that time frame.
Wow.
So you had mentioned 13 months. And sometimes people don't need that whole time, or then they reach out at 6 months. And we all know how healthcare has come to regulations and this time frame and this. So if somebody reached out more towards the end of that 13 months, does Northern Light support?
Yes.
Will provide that support, or say, oh yeah, no, we can't do that.
Yeah, we actually have done community support. So we will follow people and provide bereavement support if they're calling from the community. I mean, we're very lucky in Hancock County that we have the Hospice Volunteers of Hancock County who have wonderful bereavement groups, right? So we have those groups that we can refer people to. But as far as other grief support, bereavement support, we certainly can do that. One of the things that we've done over the last number of years is when we have a patient that maybe is hospitalized and we're going to be bringing them onto service, and they end up dying in the hospital and they never make it quite to hospice services, we'll ask them, do you want to be followed? Do you want our bereavement services? We'll follow you in bereavement. And we have a number of people that we follow that way as well.
A question from Barb. In the case when someone has slowly progressing disease, such as Parkinson's, how would one determine when it is time to call in hospice? Is this determined entirely by the physician?
I mean, I'll take it. I'll start it. So yes and no, right? So there are certain criteria. So each, I don't know how detailed we want to go, but Medicare has certain criteria for what qualifies for hospice for certain illnesses. And so we utilize that criteria. And it may not be the physician at first that's looking at it. It may be another member of the hospice team that's kind of looking at it to see. And then we're reviewing it by a physician. But as Dr. Fasciol said, it's really two physicians. So it's two physicians saying that if the disease progresses at its normal course, it's 6 months or less life expectancy for that patient. With diseases like Parkinson's, that's really hard to predict, right? So we may end up having a patient with Parkinson's for much longer than that. And as long as they're continuing to meet the insurance eligibility criteria for the illness and continuing to decline and needing the support of hospice, then we can continue with those patients. We have a few additional things that we need to do on our end to be able to make that happen, and we do that. We have nurse practitioners that will go out and see the patients and do what we call it's a hospice nurse practitioner face-to-face visit after that 6-month time frame. That has to happen every 2 months in order for us to gather the information for patients to be able, they then bring it back to the hospice physician for review to determine eligibility. Did that answer Barb's question?
I will let you know if
Okay.
she responds in the chat.
And I would assume that if the patient didn't meet hospice eligibility, then the next step is we're looking at our palliative care partners and saying, hey, this is, they're going to be able to provide you the best care and guidance and really help you plan, kind of those goals of care conversations. So that would be my assumption, that if we didn't find that they met,
Yes.
that hospice eligibility, we're looking at palliative cares.
Yeah, absolutely. So
we're involved.
yeah, we're then asking for that referral to palliative care, so the providers make a referral to palliative care. And then we're also looking at, does this patient need home health services, right? So is there a skilled home care need that they could benefit from some in-home support from the home health team? So that we're still trying to wrap people with services and making sure it's the right service at the right time for where they are in the trajectory of their illness.
I want to make a comment about those lists of criteria, because what I have learned is that the criteria was developed by a professional organization of nurses that were trying to get more patients onto hospice sooner. That was the intention. And it was never designed to be like a black and white, you must meet this to be eligible. And I think it's kind of gotten transformed over the years so that it can, those criteria, guidelines can sometimes be a barrier to hospice when that's not what they were intended. And really, ultimately, the question is, what the criteria are hoping to help people assess is the likely less than 6-month prognosis. So if that is someone's feeling based on their experience and education, then you make the case. It doesn't have to fit these criteria every check marks down the list.
Clarification for that initial question. She says, so it's 2 physicians question? And is that correct? It's 2 physicians who determine eligibility?
For hospice, yes.
For hospice.
It's the referring physician and then a hospice physician.
Thank you.
There is a rare exception, I will say, if the patient doesn't have a physician, like a referring physician, and we live in an area here where there may be people visiting from afar, right? So they may not have a physician here, and if they were to go into a decline and need hospice services, we wouldn't want them not having a local physician to be a barrier to that. And so there are instances where our hospice physician can be the one physician. That's an exception, right? But that can happen.
So you've talked about 6 months, and I've heard you say a year as well. And so can you talk in regards to what happens if somebody lives longer than that 6 months or a year? Do they come off of hospice? How long can they stay on? How long have you had people on hospice? I know.
You have a opinion?
The benefit of some insider knowledge, that's all, but I say that because I think there's my time people think, oh, hospice, I'm gonna die. And hospice is not about that. It's about giving them back their life, their choice to do things. And they can live, they do live longer than.
Yeah, and Medicare also expects that when somebody starts hospice services, they're actually gonna improve a little bit with that added intervention. So in that first 3 months of hospice, let's say that we may see some improvement, right? And we have to justify that that's related to the hospice intervention in order to be able to continue.
And then families start like, well, why does he need or she need to be on hospice?
Right.
If he's good, but
Right.
this is also.
So years, some people have been on hospice for years. Now, our average length of stay is much, much smaller than that, right? My concern is not so much our long length of stay, it's the short length of stay when we are admitting somebody and they're dying the same day. So we're helping them get home from the hospital. This is one of the greatest challenges, right? We get a referral and the patient wants to go home to die. How do you make that happen? And you got to do it in a few hours. That's just like going to the islands, or the outer islands, right? You band together and you figure it out, and you make that happen so that patient can get home to die. Does that, what is the like, we will never be reimbursed for what that actually costs us to do. Like, that's not even, that doesn't happen, but we do it because that's what's right. That's what that patient wants. And they have the right to be able to go home to die if that's their choice. And so we work together with the discharge planners, with palliative care, with whoever to be able to pull that off.
I'm going to just add to that I think it's a matter of being able to prognosticate, which is sometimes very difficult in certain diseases, and also having a really good role of care conversation. There are diseases which are very easy to prognosticate. Cancer is easy to prognosticate. The problem with cancer is you can maintain a really good quality and functional level up until very close to the end. And then we end up in situations like Erin said, where we have hours to get this patient home because now they don't have anything left to live. There are other diseases which are very difficult to prognosticate, like the one that Barb was mentioning. Parkinson's is one of them, dementia is one of them. So those are hard to prognosticate. And then there are kind of the in the middle ones, like the congestive heart failure patients who come to the hospital, get diuresed, get a lot better. So it's hard to convince those patients to accept hospice at that time if every time when they come to the hospital, they get better. What you have to explain to them is, yes, they get better, but if you look at their trajectory, they never quite get back to where they were. So we oftentimes draw this kind of like course on a patient, in the patient's room on their board, so that the families can see that, yes, they got a little better, they're not where they were 3 months ago. And also to let them know that they might not survive the next time they come to the hospital. So after their 5th hospitalization, they will be more accepting of hospice. Sorry, I talk too much.
No, you don't.
This is great.
Just kind of off what you're saying in regards to they're going to the hospital, they feel better, they go to the hospital, they feel better, go home and all that. And a lot of times people are not on hospice or even palliative care for that matter. So how can the hospitals, how can the providers work to, because absolutely, there's a lot of times where people get on the hospice at the very end of life, and to get those individuals on sooner. How do you break through that? How is Northern Light doing anything to try and open that up to other providers and giving that education that's kind of thing out there to the community as well as providers? Because we all know, sorry, that's not but providers can be a little, no, they're not going to that. We're going to continue to move forward with that. So how does that all kind of help to be patient-centered, to do what's right for the patient?
I think encouraging palliative care, right? Because we can have palliative care much longer,
yeah.
Right? And so encouraging palliative care to help have those conversations and be looking at that whole picture is one of the major things that local providers could do earlier, right? So getting that education out to providers to get palliative care involved earlier. And then the palliative care team is going to then also help that provider or make the referral when it's time for hospice and have some of those conversations so people are more ready for that. We've received patients on the other end of palliative care consults, even the telehealth consults, and it's a huge help because that goals of care, everything is sort of outlined what the patient wants. And then we know we're going in and we're helping them to fulfill what it is that they want. So whether it's in the clinic palliative care, in hospital palliative care, telehealth palliative care, like whatever it is, having that level of service as soon as they can, right, it is super helpful in their overall plan for what their life is going to look like. And that could be, as Hasmina mentioned, that could be 7 years of their life. What is that going to look like? And then as far as you're asking about community outreach, and we do have our provider relations liaison here tonight, Susan Shar. She covers Hancock County for us. And she is fairly new in her role, certainly not new to healthcare, or she lives in our county, and she's going to be doing some outreach to providers and has already set up some of those meetings. And we're always happy. Like it's great for us. I mean, I've gone to some of the MDI clinics before, and if we can meet with providers and say, what is it you need? What will help you? What can I do to help you? I mean, that's what we want to do. We want it to be collaborative. We don't want it to be in silos or boxes. We want it to really surround a patient.
And I will say that there are a lot more providers who are very open to palliative care. Specialties that you would not necessarily expect that from, like our cardiology group at Eastern Maine refers to us a lot, to the point where we sometimes say, okay, this is their fifth admission, they're still going to want to come back to the hospital, so maybe not this time. But same with oncology. I mean, it's completely different from where it was maybe 10, 20 years ago. We see a lot of their patients. A lot of our oncologists now have trained in centers where they had to have palliative care rotations or have additional training in palliative care. So we have very good relationships with them, and we see those patients a lot earlier than we used to see before. Sorry.
Just a quick question on, there's obviously a lot of confusion, a lot of questions regarding all the different aspects of home care, hospice, and palliative care. How do the families and the individuals on MDI, how do they connect with all of you? Is it always through a referral, or is there a way when they have questions that, how do they find you?
Word of mouth, no. I mean, sometimes I do get a call that way, right? Like, oh, I got your name from so-and-so, and, you know, I have some questions for you. We do get, as I mentioned, referrals from, you know, hospitals and providers, local facilities, right? Assisted living or long-term care facilities could do that. But patients can call, or families can call and inquire. We have that happen all the time. They call into our 1-800 number and they say, I'm looking to gather some information about home health or hospice or palliative. And so then we call and we provide them that information and just let them know. And so the information is, everybody can have it, right? Like if my insurance benefit has, you know, I'm able to have palliative and hospice under my insurance benefit, I want to know what that benefit is, right? So we can always talk to people about what our programs offer and what you know, how that's covered and what that looks like.
Very often when I'm doing the telehealth palliative care consults and someone's in the hospital and they're going to be stuck there for a little bit, I like to ask for hospice informing visits, because then they'll have someone come in person who'll tell them about the hospice benefit. Even if they're not going to choose it that time, they'll know for the next time.
I can speak a little bit more directly too about that MDI provider group. My name is Tiffany. I'm the manager for the integrated care team, which encompasses the palliative care team at MDI. Our provider groups are really in a close relationship with our palliative care team, who really does a great job at navigating goals of care and difficult conversations, but also for advocating, hey, it's time to get hospice in the door. And they help bridge that gap and help get the right people into place to support the patient, meet the patient where they're at, and get the patient with what they need. And our provider groups work really closely with our integrated care team, and we encourage the palliative care team to be embedded as soon as possible in the plan of care for the patient. So I think our palliative care team does a great job at saying, you know, yes, let us bridge the gap, but this is like, let's get hospice in here, let's get an informing visit, let's take the stigma and fear away, and let's help you guys transition to what you really need right now, which is hospice care, or let us help navigate difficult conversations and goals of care, and we'll kind of guide you down the path of when it's time to kind of get hospice in the door, which I think is awesome for our community, because we've got people who live right here, who are right here, who are able to help advocate and have those difficult conversations.
And it's nice because members of the palliative care team will just call me like, hey, Erin,
yes,
you know, we're putting this referral through, we have this patient, I want to tell you a little bit more about the patient so your team, you know, knows, you know, how to better care for them. And that's super helpful. That's just picking up the phone and calling your neighbor and collaborating together.
And they're also great when patients are in the hospital, because although, you know, dying is part of healthcare and it's part of living, it's scary for even healthcare providers. And so our palliative care team is in the hospital and is able to help the team that's providing care for the patients navigate that process, encourage them to call the hospice nurse so that the hospice nurse can come in and help navigate that process and help walk them through, again, difficult decisions or difficult conversations. And I think it's invaluable to have that bridge and to have these two entities, which are invaluable to the community, working so closely together with an open relationship. I think it's beneficial for all of us, for sure.
I think it's good to point out too that home health can absolutely be that bridge to hospice as well. We work across our service lines daily Right, so typically for home health, we're seeing patients after they have an acute episode that occurs. But let's face it, most of our patients do have chronic things that are going on as well. So as that acute phase is started, like they're starting to come out of that, that chronic condition is still there. And like we've talked about, it can be kind of scary, right, to have that goals of care conversation with that patient. The hospice team is really skilled and they're the experts in that. So to pull them in and to help with those conversations early on to get that patient and their family all the information they need so they can really receive the care where they need to be receiving, it's really important.
Excellent. Wow.
And Erin's team is great at it.
Thank you all. You've really been amazing. We only have, I think we're down to the wire here. We've only got a minute left. Any last thoughts, comments, questions? Oh, our favorite audience. There is no prize. I don't know if anything is going to be
One last question for the whole panel.
Okay.
One is because everybody's talking about goals of care, and we are an aging population here in Maine. When should we start talking about goals of care? I don't have a chronic illness, but I'm aging like everybody else is. Should I start to have that conversation?
Yes.
Day one.
Absolutely.
Yeah.
Easiest time to talk about it is when you don't need to be talking about it. That's, I
And you
always
don't
say.
have to frame it as goals of care.
Right.
Sometimes it sounds really kind of cold and impersonal. But just stop learning to know your patients, which is what I try to teach our fellows and our residents and our students. Just ask the simple questions. Just be like your cab driver, your hairdresser, who in 5 minutes knows more about you than anybody else. I mean, really, just ask. People will answer. You'll know a lot about your patients in a 5-minute conversation. Sometimes you just start with that and you break the ice and you start to learn what's important to them. And from there, it's an easy conversation to figuring out what their values are and how to channel those into a more formal goals of care conversation.
So it sounds like any time of life when things are relatively normal is a great time to think about how you may want to approach things when life goes sideways. Is that about right?
One more question from the online crowd. Sebastian asks, are there ever opportunities for people to volunteer in palliative and hospice care practice? For example, a COA student thinking of doing an independent study on the subject? And if so, what are the ethical concerns around that?
We are always happy to have volunteers. We do have volunteers in palliative care. So at Eastern Maine, they just have to contact the volunteer services office and they connect us with them. And then we meet with them and if we think it's a good fit, they do some training and we're happy to have them, so.
Excellent.
And hospice volunteering is also an option. I just completed the hospice volunteer training through Hancock County, Hospice Volunteers of Hancock County, and they provide palliative volunteers and hospice volunteers, and even the training is really like an experience.
Excellent. You have one last question?
I could be opening up a whole lot
Oh,
here.
no, okay.
I'm just wondering how the death with dignity fits into palliative as well as hospice.
I think that's a
It's
fair
a
question.
different can of worms.
But I think it's something that's out there and
I can see.
the community needs education on that.
So the Death with Dignity Act in Maine, it has made what I prefer to call the medical aid in dying process legal in Maine. And providers have an option whether they want to participate or not. And so palliative care providers are no different than that, in that they can make a personal choice. Hospice is recommended for someone who's going to go through that process and will support the person and their family in that decision, although they can't practically be there.
So we don't arrange for that, or our physicians aren't signing for those medications, but we certainly are doing what we do and providing support around the patient. And if that's what their goal is, then we're kind of walking with them through that. We're not encouraging that, and we're not there when they are ingesting the medications.
Excellent.
And it's not part of our hospice plan of care.
So,
It's important. Thank you for asking. Well, with that, any other last thoughts, comments that you'd like to share?
It's a very well-educated audience. Thank you for your questions and your time and all of your commitment, and my fellow panel members too. This is an important work, and I'm glad that we get to share what we love with you.
Well, I
Thank
think
you.
on behalf of the audience that's here and those that are listening tonight and that will watch this in the future, I want to thank you for your expertise, professionalism, and guidance through this topic that often we want to pretend doesn't exist. I know many of us understand the value that you offer us all, and so thank you for clarifying the nuance and helping us understand better the great things that you're doing every day to support those facing illness in our community. So if you want to learn more about how you can support Northern Light Health and all of its endeavors, please do not hesitate to reach out to Northern Light Health Foundation. We'd be very happy to engage with you and help you discover ways in which you can make philanthropic impact in your community. So thank you all, and we want to give you a very good round of applause to send you off. Any more questions?